Welcome, everyone, and thank you for participating in today's Get the Medications Right Learning Network webinar, A Better Way to Manage Medications. My name is Amy Brooks. I'm the Director of Strategic Initiatives at the American College of Clinical Pharmacy and one of the leads on the Best Practices and Innovative Solutions subgroup of the GTMRX Practice and Care Delivery Transformation Work Group. On behalf of the Institute, we are delighted you are joining us today. Next slide, please. During today's presentations, all participants will be in listen-only mode, but we do encourage you to use the chat feature to submit questions throughout the presentations. At the end of the presentations, I will pose your questions to our experts and include as many as time will permit. Please also note there's a link for a recording of today's event that will be sent to you in approximately 1 week, and both the slides and recording will be available on the GTMRX website. Today's speakers have prepared materials to help you describe the problem of medication non-optimization and its financial and clinical impact on patient health and well-being, distinguish between the common practice of medication therapy management and the specialized, clearly defined practice of comprehensive medication management, or CMM, assess the evidence for the efficacy of CMM in achieving the quadruple aim of better care, lower costs, improved patient experience, and provider well-being, and identify key barriers to wide-scale implementation of CMM. Next slide, please. Before I turn it over to our expert presenters, I'd like to provide a little bit of background to set the stage. The Get the Medications Right Institute is a multi-stakeholder coalition formed to bring critical stakeholders together, and we are all bound by the urgent need to optimize medication outcomes and reduce costs. GTMRX works to enhance life by ensuring appropriate and personalized use of medications and gene therapies. In order to do this, the Institute focuses on 4 key areas: practice and care system transformation, payment and policy solutions, precision medicine via advanced diagnostics, and health IT to support optimized medication use. Next slide, please. The work of the Institute is necessary to address challenges in optimizing medications within today's healthcare landscape. Increasing medication complexity is among those challenges. There are over 10,000 prescription products currently marketed in the United States, and 80% of patients leave their primary care provider office with a prescription. Medicare Part D beneficiaries have an average of 3 to 4 different prescribing providers. And this translates to about 30% of adults taking 5 or more medications and over 4 billion prescriptions annually. To make matters worse, primary care providers have about 49 seconds in a typical 15-minute patient visit to talk about new medications. Considering these facts, it's not surprising that suboptimal medication regimens and subsequently poor patient outcomes are all too common. Next slide. Adding to the challenges of medication complexity, our nation's primary care physicians are overburdened. Primary care physicians see an average of 20 patients per day. After each visit, an average of 16 minutes is then spent on electronic health record work, including chart review, documentation, ordering, and others. These and other increasing demands, limited reimbursement, and less time with patients all contribute to a negative impact on physician well-being. Recent data supports that over half of practicing physicians are experiencing substantial symptoms of burnout. Next slide, please. Ultimately, we have a healthcare system that is fraught with the negative consequences of non-optimized medication regimens. This leads to approximately $528 billion of annual waste from hospitalizations, long-term care admissions, emergency department visits, provider visits, and additional prescriptions. And even more importantly, over 275,000 lives lost. It's important to note that these outcomes are the result of a wide array of medication therapy problems beyond adherence, including inadequate therapy, adverse reactions, inaccurate dosing, and unnecessary therapy, to name a few. Next slide, please. We believe the solution is comprehensive medication management. CMM is a systematic approach to optimizing medications where physicians, qualified clinical pharmacists, and patients collaborate to get the medications right. Next slide, please. Now, to get to today's presentations, I'm delighted to introduce you to our expert presenters. We will start with Dr. Mary Roth McClurg. Mary is Professor and Executive Vice Dean and Chief Academic Officer at the University of North Carolina Eshelman School of Pharmacy. She practiced for 12 years as a clinical pharmacist in primary care within the VA health system and in the interdisciplinary geriatric clinic within the Department of Geriatrics at UNC Healthcare, providing direct patient care as part of an interprofessional team. Mary has focused her research efforts on advancing comprehensive medication management and the role of the clinical pharmacist as an integral member of the primary care team, with the goal of optimizing medication use and improving patient care in patients with multiple chronic diseases. Mary is a fellow of the American College of Clinical Pharmacy and a distinguished fellow of the Get the Medications Right Institute. After Mary's presentation, we will hear from Dr. Annie Eidecker. Annie is the Senior Medical Advisor on Clinician Experience and Senior Medical Advisor on Clinician-Patient Relationships at Health Partners. She is a graduate of the University of South Dakota School of Medicine and completed her residency in family medicine at Bayfront Medical Center in St. Petersburg, Florida. She served as a medical officer in the United States Navy at Marine Corps Base Camp Lejeune in North Carolina for 4 years prior to joining Health Partners in 2006. She practices at the Health Partners Arden Hills Clinic, where she also served as the clinical medical director for several years before stepping down to take her current leadership role. Thank you both sincerely for joining us today. And with that, I'll turn it over to Mary.
Thank you so much, Amy. So I'll share a few things with you on this slide and the next that I'm sure many of you are quite familiar with, which is one of the reasons why medication optimization and comprehensive medication management becomes so important. The first is just a rise in specialty medications and gene therapies that are already beginning to transform care, and this will only continue. For many decades, we've been dealing with the delivery of healthcare being fragmented, which negatively impacts the quality of care. We know that there is a shortage of primary care physicians. There's often uncoordinated care between specialists, primary care, pharmacies, and so on. So that feedback loop is often not closed when caring for patients. We have more medications than ever, prescription, over-the-counter, herbal therapies, and the FDA is approving prescription medications at a faster pace. And then obviously with prescription drug costs rising, this sets us up for a lot of medication problems and misadventures. Next slide, please. Some additional factors that need to be considered are the pharmacogenomics. We talked a little bit about gene therapy earlier, but in this case, pharmacogenomics is really beginning to inform which combinations of medications and dosages are most effective and safe for particular patients based on their DNA and based on their genetic makeup. We also have the 21st Century Cures Act that's accelerating the discovery, development, and delivery of cures at a faster pace also than ever before, and a real targeted effort here. The population has been aging for quite some time, so people are living longer with more chronic diseases, and with more chronic diseases comes more medications. And we do know that pharmacists have unique expertise in optimizing medication use for patients and are key members of the interdisciplinary healthcare team. And we'll talk more about this in another slide. Next slide, please. So I mentioned the word medication optimization earlier and wanted to share a little bit of a vision about what that means to us and to GTMRX. But medication optimization is a patient-centered, collaborative approach to managing medication therapy that is applied consistently and holistically across care settings to improve patient care and reduce overall healthcare costs. Now, part of medication optimization is that you have to have an optimal regimen. So your drug regimen itself needs to be appropriate and optimal. You have to have optimal use of that medication. So medications can be prescribed and be optimal with respect to the drug regimen and the drug therapy regimen, but they have to then be optimally used. They have to be taken. They have to be taken at certain times of the day. And then obviously, as part of that, there has to be patient care team communication around the patient's use of the medication. That all results in this ideal state or this optimal state that's referred to on this slide as medication optimization. That then helps to achieve patient-centered and therapeutic goals and contribute to achieving the quadruple aim of healthcare. Now, one of the things about medication optimization is that there are many different ways to optimize medications. What we'll be talking about today is the role of comprehensive medication management in that process of medication optimization. And comprehensive medication management really means that you're providing whole person care around all of the medications a patient may be taking, not just the acute issues of the day, for example. So we'll be talking a lot about comprehensive medication management as the intervention or the patient care delivery service to optimize medications in this case. Next slide, please. So we talked a little bit about CMM. I'd like to go through the entire definition because there's so many really important components to this. But CMM is a patient-centered approach. I mentioned it's whole person, so it's optimizing medications and improving patient health outcomes. It's delivered by a clinical pharmacist who works in collaboration not only with the patient and his or her family and caregivers, but also the healthcare team. This ensures that each patient's medications, I mentioned earlier, prescription, non-prescription, herbal, dietary supplements, and so on, are each individually assessed to determine that they have an appropriate indication, that they're effective, that they're safe, and that the patient's able to take them as intended and adhere to them. So you can see the importance of the comprehensive nature of this in really optimizing medications for patients. Next slide, please. So there is a lot of growing evidence for CMM. Historically, there have been pockets of really great evidence across the country, a lot of it out of a few of the integrated healthcare systems in Minnesota in particular. But even more recently, there's more and more data emerging on the impact of comprehensive medication management. And I'd like to point your attention to the citation at the bottom, American Journal of Medicine, and there's a screenshot in the top right-hand corner of this article. I would encourage all of you to grab this and read this. This is a really wonderful review of the impact of CMM on achievement of the quadruple aim. And the authors in this case really did a fantastic job of pulling together the evidence and putting it kind of all into one place. And so highly encourage this read, Assessing the Impact of CMM on Achievement of the Quadruple Aim. When we talk about the quadruple aim, we're talking about both better care, reduced healthcare costs, improving the patient experience, and then improving that clinician experience. And Amy alluded earlier to improved provider well-being and reduced burnout, and that's exactly what we're talking about here. I'll go into more detail on the next slide. So a little bit about the evidence for CMM. So when we talk about better care, which on the pie chart is reflected in the quadrant that says clinical quality metrics, often better care could mean reduction in medication therapy problems, meaning we're preventing adverse drug events. But importantly, it means that we're achieving the clinical and patient care goals of the individual patient. This could be an improvement in their diabetes care, heart failure care, hypertension, osteoporosis, a whole host of whatever ailments and diseases the patient may be experiencing. So CMM does have evidence that it results in better care, significant evidence that it improves metrics around a number of conditions. Also for reduced healthcare costs, there have been a number of cost studies in the literature that have looked at return on investments or ROI ranges anywhere from 3-to-1 to 12-to-1. There are reductions in emergency department visits and hospitalizations that lead to this cost reduction in overall care. So the benefit of CMM really has shown a positive impact on cost of care as well. Now, improved patient experience and improved provider well-being are getting a lot of attention these days. Patients, there's a lot of evidence that patients are more satisfied, they're more engaged, they feel with the clinical pharmacist as part of the team working on medication optimization, that they're establishing these trusting relationships that seem to endure. For provider well-being and the provider experience, there's been some great work that's been done as well, and it's also cited in the article that's on the slide here. Some of this work has found that when a clinical pharmacist is part of the team providing comprehensive medication management, there's reduced burnout on the part of the clinicians. There's decreased workload because the pharmacist is able to help offset some of the load that's on the physician or the team. There's decreased mental exhaustion, enhanced learning by the providers around medications. Patients now have greater access to the providers because the pharmacist is offloading some of their work. And then there's just this general satisfaction that care of their patients is being improved. So there's some great data out there on that as well. So lots of evidence for CMM. I know when I entered the profession a couple of decades ago, we didn't have this level of evidence for CMM that we have now. So we were often having to make the case in many regards for this. So now we have this evidence and it continues to grow. Next slide, please. One of the more recent studies that has hit the press, and you may be familiar with it, the National Academies of Sciences, Engineering, and Medicine released a report a few months ago entitled Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. Now, while this article doesn't talk specific, although there is a section in there about pharmacy and about CMM, the study itself was very comprehensive in nature and really talked about how do we improve the delivery of high quality primary care. And a few of the things that I wanted to point out here, if you haven't had a chance to take a look at this report, I would encourage you to do so and look at the recommendations of the committee. One is about reforming payment models and really reforming payment models so that payment is made for the improvement of healthcare in the spirit of team-based care. And then I would also encourage you to take a look at the Designing Interprofessional Care Team section. This is in the workforce chapter. It really talks a lot about the role of the pharmacist and the role of many other healthcare professionals on the team, and really the importance of medication optimization to the delivery of high quality primary care. So just something more recent that would be worth a read as well. Next slide, please. GTMRX has come out with this wonderful pictorial that illustrates 10 key steps to achieving comprehensive medication management. I'm going to walk through these at a high level just so there's an appreciation. I quickly saw something pop up in the chat about CMM being ideal. I didn't capture the whole question, but CMM is something that is really pretty intuitive when you think about it. You want to identify patients that have not achieved clinical goals of therapy, patients that are at high risk for medication burden or medication complexity or increased hospitalization use. And then you have to understand the patient's personal medication history, how they're taking their medications, what's going on at home, what problems do they have managing them. Then you need to identify what they're actually doing. Are they adhering? How are they using them? An important step is then to assess each medication for appropriateness, effectiveness, indication, and adherence. And then identify what medication-related problems or drug therapy problems exist in that patient. Once those are identified, then it's important to come up with a plan, a care plan that you develop in collaboration both with the patient and the primary care provider that addresses the patient's needs while meeting their healthcare goals. You have to ensure that the patient understands and agrees with this, or it won't be implemented as intended. And then an important part of this too is then to document and communicate what the recommendations are for achieving medication optimization and improvement of care. A critical step then is follow-up and ensuring that this is an iterative process. Addressing a patient's medication complexities at one visit is addressing the patient's medication complexities at that visit, because much changes between visits. And it's important to ensure that there's adequate follow-up monitoring and that this is iterative over time. Next slide, please. One of the final things I want to share with you is some research that we did out of UNC Eshelman School of Pharmacy and also at the University of Minnesota School of Pharmacy, in which we really looked at comprehensive medication management and what comprises CMM. And we like to depict that with this triangle that there has to be a philosophy of practice. There are 5 core tenets to the philosophy of CMM, and you can find more information in the link here at the slide. But a really important one is just that the pharmacist assumes responsibility for optimizing a patient's medication therapy. That is their key role on the team in working with the team and the patient. Other aspects of these tenets include team-based care, developing a relationship with the patient, and so on. So that's philosophy of practice, and that's really the foundation that CMM is built on. There's also the patient care process. And again, the link here at the bottom will walk anyone through the patient care process who wants to know a little bit more about what that is. But essentially, it's depicted at a high level in the wheel to the right. And I summarized it a bit when I walked through the 10 steps of CMM. You have to collect the appropriate information from the electronic medical record and importantly from the patient. You make an assessment of those medications. You develop a plan for those medications. You implement that plan, and then you provide that iterative follow-up and monitoring and ongoing evaluation. The reference down at the bottom of the screen really walks pharmacists and others through a process of what does it mean to collect? What are the steps embedded in that? What does it mean to assess and plan and document and follow up and so on? So much more detail follows in that link. And then finally, the third part of the CMM triangle here is what we refer to as the practice management system. We also have a few publications we can share around what the practice management system means. And this is essentially, if I can summarize, practice management system is if I'm working with Dr. Adeker in her clinic, and I know how to take care of the patient care process, and I know how to interact and interface with the team and the patient. I also have to set my service up within her clinic. So what does that look like structurally? What does it look like with private office space? What does it look like from a reimbursement and billing standpoint? How do I sustain my services? How do I evaluate them to make sure I'm having an impact on the team? And so you can see the patient care process is about my relationship as a pharmacist with that patient and that team and improving that care. And the practice management system are all those structural and functional supports that we need around us in order to deliver a service that's effective, efficient, and sustainable. And again, we have many publications and articles that go into these 3 steps in much more detail that we can share. Next slide, please. I believe now I'm turning it over to Dr. Adeker, who will walk us through a real life example of how this unfolds in clinical care. Annie?
Thank you, Mary. Really nice job sort of framing up the conversation. And thanks to all of our listeners. So as per the introduction, my name is Annie Adeker. I'm a family physician. I've been in practice at Health Partners for the last 16 years. And for more than a decade, I've been fortunate to work very closely with a pharmacist with this notion of comprehensive medication management. And so what I'd like to do over the next few minutes is just sort of show you what a real life example of what this actually looks like in a primary care clinic. And we'll be using an example of one of my own patients to tell this story. Now, this is by no means a comprehensive example. I could have put a lot more into this example. I didn't touch on things like herbals, other supplements that a patient might be taking. Didn't really put much in here about cost, but what I wanted to try to show is really some of the key clinical aspects of how comprehensive medication management can support patient care in a primary care practice. So we're going to talk about a 57-year-old female patient. She's a very typical patient in my practice. She has hypertension. She's had type 2 diabetes for a number of years. She has obesity, hypothyroidism, and she suffers from anxiety disorder as well. You can see her current medication regimen, which is going to look very familiar to any of you who practice in primary care. This is a very typical patient that you might be seeing. So she takes lisinopril for her blood pressure. She is on metformin for her diabetes. She's taking levothyroxine for her hypothyroidism. We have her on a statin, and then she also takes Paxil for her anxiety disorder. Her vital signs you can see listed there. She's got a blood pressure, which is a little elevated today. Her weight is 175 with a BMI of 34. Recent data show that her A1C is now 7.8, which is up from 7.1 6 months ago. TSH is within normal limits at 90. Her LDL is 86, and her GAD-7 is 2. And I'll just make a note that this is a very typical patient that we see in primary care. And all of this data that I am reviewing and needing to interpret and think about when I'm seeing this patient in my 20-minute office visit, as you know, Mary and the introduction really did appropriately tee up. This is a very real life scenario. So the things that I'm thinking about as her clinician are, of course, I don't like her blood pressure. Her blood pressure is higher than I'd like to see for this patient. Her weight, of course, is a concern. I'm concerned about this trending up A1C. And this would be a poster child patient for what we've observed over the last 18 months during the pandemic, right? With everyone at home, a lot of people have gained weight. Her A1C is climbing. Of course, I want it ideally less than 7, given her age. And, you know, I know that because she's now over that threshold of 7.5, she has a high likelihood of being over 8 next time we check it. So definitely want to think about that. Her LDL is not at goal for where I'd like her to be as a diabetic. I'd like to see that less than 70, of course. Her TSH is actually fine, but let's think about what this patient is concerned about. So I'm thinking about all these things as her clinician. What she's really worried about when I speak with her is actually her weight. She's gained weight over the last 6 months. She's up 15 pounds. She does tell me that she's been taking her medications regularly, which is great. And she also tells me, and this indicating that she's got I think an above average level of engagement, that she's actually checking her blood pressure at home, which of course I really appreciate. And she goes on to tell me that her readings have been elevated, which is consistent with what I'm seeing in the office. She also mentions that she's been having some loose stools or diarrhea, which she had not previously disclosed to me, and that this had actually been happening several times per week. But the thing that she's actually most concerned about is her weight gain. And she's done a little online reading, which is not unique for our patients. And she knows that Paxil can cause weight gain. So what she's really wondering about is her thyroid okay? Because she knows that thyroid problems can contribute to weight gain. And she's also really wanting to know about that Paxil, which I should say anecdotally, she's been on for a number of years and the weight gain is relatively recent. So that's the clinical case that we're going to dive into. And let's go to the next slide and see what we do with this. So again, her main concerns today are the weight gain. That's really her primary focus. So if I, as a clinician, I might have this sort of large agenda of all the other things that I want to focus on. But if I don't meet this patient where she's at and really spend some time thinking through this weight gain with her, she's not going to go away feeling like she got the full value of her primary care visit with me. And I also really need to spend some time addressing her concerns about her thyroid and her use of Paxil, because as I mentioned, she's an engaged patient. She's done her own research, and she wants to make sure that those potential aspects of her care are being thought through and addressed today. So again, clinically, I'm also worried about her uncontrolled blood pressure, concerned about her increasing A1C and her weight gain, which again is one of her primary objectives, the LDL we talked about, and then of course her anxiety disorder. So we can go to the next slide. So what did I do during this visit? So the first thing is we're going to increase her lisinopril to 20 milligrams daily. This is a patient who already is on antihypertensive medication. She's familiar with lisinopril. She's tolerating it. And so this is not a long, detailed conversation with a patient like this to talk about the importance of getting her blood pressure to goal. So this is actually a relatively small part of the conversation. She agrees to go ahead and up her dose to lisinopril 20 milligrams daily. We talk about the stepwise augmentation of this therapy and where we might be headed. Also the importance of getting to goal. And then I have a brief conversation about her blood pressure monitoring technique with her, because I want to make sure that if she is taking the time to actually do this home monitoring and provide me with this data, that it's actually data that we can trust. And we're going to talk more about that in just a couple minutes. We're also going to increase her atorvastatin to 20 milligrams daily. The way that me and I and my colleagues try to practice primary care is we definitely want to meet patients where they're at. We definitely don't want to overwhelm them, but we also recognize that when patients have high deductible plans and that they may be limiting their care and their interactions with us due to cost and other issues, we want to try to get the full advantage that we can out of every visit within reason. So we see an opportunity here to augment her statin therapy and try to get that LDL less than 70. So that's another thing that we're going to do at this visit. So we know we've made 2 medication changes in this office visit. And then we need to have a conversation about sort of the other things that she's concerned about. So we talked about the fact that her TSH would indicate that her thyroid is actually well regulated. And having had that conversation with her, she's comfortable with that. We're not going to make any changes in her levothyroxine dose. We also talk about her GAD-7. Which is actually indicating that her anxiety is under good control with a GAD-7 score of only 2. And we table the discussion on Paxil, acknowledging that yes, Paxil can cause weight gain, but that there are some other things that we might do vis-a-vis her diabetes management that could help address her weight gain and also bring her under her diabetes into better control. And so through a process of shared decision-making, we decide that we're going to focus on that as sort of our next horizon in her treatment. And in order to do that, I'm going to tee up a conversation with her about possibly introducing a GLP-1 agonist for her diabetes management. As I'm sure you all know, there's good data to support augmenting metformin therapy with GLP-1 agonists for a variety of reasons. And we know that GLP-1 agonists can help to address the concern, which is one of her main concerns today, and that is weight gain. But I also know that it's very likely that we're going to be doing an injectable form of this medication. And in order to get the teaching and really for her to get sort of the full scope of what she needs to be successful with a shift to this type of treatment, we're going to engage a pharmacist. So I'm going to introduce her to the notion of comprehensive medication management during this visit, talk to her and tee up what she might expect to get from a visit with a pharmacist. And she agrees to that. And so we make that plan. And so we've made, again, the 2 medication changes with her lisinopril and her statin. And now we've set the expectation with her that she's going to be seeing an expert member of my team to talk about next steps in terms of her diabetes management. And so we'll go to the next slide and see what happens at that visit. So she sees my colleague 2 weeks later. The comprehensive medication management visit with the clinical pharmacist has a number of pieces. The pharmacist, of course, assesses the potential side effects of the medication changes that we recently made. So does confirm, in fact, that she's doing fine with the higher dose of atorvastatin, and then reminds her that we should get an updated lipid profile in 4 to 6 weeks so we can monitor the efficacy of that treatment. She also talks to her about the side effects, potential side effects of lisinopril, and does ascertain that no, in fact, she's tolerating this higher dose of lisinopril without any difficulty. But it turns out that her blood pressure is still not at goal. And the pharmacist takes the additional step of actually, since the patient was kind enough to bring her blood pressure cuff in with her, she has her actually put the blood pressure cuff on. We do a side-by-side check. We confirm that she's using the cuff correctly, that the readings are consistent and accurate with our calibrated machines in the office. And so through, again, a process of shared decision-making and education, the clinical pharmacist says, you know what, let's go ahead and bump that lisinopril dose up to 40. Let's further augment that therapy, take that stepwise approach. And we'll see if that higher dose of blood pressure medication can help get you to the goal. Patient's comfortable with that. They agree on that plan. The clinical pharmacist does spend some more time talking about with this patient regarding the diarrhea, which you'll notice, didn't really spend a whole lot of time on with her because we had so much that we covered in that visit 2 weeks ago. But the pharmacist really hones in on that diarrhea, gets a little bit more information, and determines that maybe this is a side effect of the metformin that she's taking because she's been taking the short-acting formulation. So she very appropriately suggests to this patient that maybe we should try the XR formulation of metformin instead. And in fact, they agree to make that change. And then finally, And again, one of the primary reasons that I sent her to the pharmacist was that they have a much more detailed conversation about the notion of a GLP-1 agonist, what the patient might hope to gain from that. They go through the process of shared decision making, review this in terms of cost and whether or not the patient can actually afford this medication based on her coverage. And in the end, they agree that they're going to add Trulicity, so she gets the teaching on how to actually administer it. And they agree that that's going to be the next step in her diabetes treatment. So let's see what happens 4 weeks later. We'll go to the next slide, or 6 weeks later, excuse me. So now she comes back in to see me. It's now been 2 months since I last saw her. We've had those interval adjustments in her medication. And the good news is that her blood pressure is now at goal. So she's on lisinopril 40 milligrams. Blood pressures are looking perfect. She's still monitoring at home. We know that her readings are accurate and that she's comfortable taking them correctly. The clinical pharmacist also wisely suggested that maybe we should check creatinine and potassium again, because now we've changed her dose of lisinopril a couple of times. So she had that done before I saw her. Fortunately, those numbers are looking great. We also got a lipid panel when we were getting those labs, and her LDL is looking excellent now at 64. She's tolerating that higher dose of statin. Even better news, that diarrhea that she was experiencing, those loose stools a few times a week, that's gone away since we switched her over to the XR formulation of metformin. So she's really happy about that. We also checked an A1C since we were doing labs, and she's delighted to see that her A1C is coming down. It's now 7.2 with just a few weeks of that GLP-1 agonist treatment. GAD7 is still stable at 2. We didn't bother to check a TSH again because we didn't do anything with that. And what the patient is most delighted with is that her weight is now down 5 pounds from where it was 2 months ago. So she's happy. I'm happy. The medication therapy management or CMM pharmacist is happy because we've really met this patient where she's at. We've achieved the clinical goals that we had for her. We've also engaged her, and she's happy with the outcomes vis-a-vis fewer side effects, tolerating her new regimen, which she can afford. And she now has another trusted member of her team that she can look to for guidance and support, in place of or in partnership with me to better support her care. So we'll go to the next slide. So what are the key takeaways here? So again, I think Mary did a really nice job of sort of illustrating the ecosystem that this exists in. But the key takeaways that we want to know about is that, this clearly is an example of how we're getting a better outcome for this patient. Better outcomes support lower cost and reduce total cost of care. We saw in this example improved patient engagement, where not only were our clinical goals met as well as her clinical goals, but the things that were most important to her that she really cared about, the side effects, the weight gain, the weight concerns, those were also addressed through collaboration with the clinical pharmacist. She's now having fewer side effects. And from my perspective as a clinician, as we think about the quadruple aim, this is a better experience for me. I know my patient got better outcomes and better care. I've learned something through collaboration with my pharmacist about her metformin causing the diarrhea side effects that I just, didn't have top of mind when I saw her. And in total, we've been able to partner together in this example to give this patient a better care experience all around. So with that, I'm going to turn it back to Mary to talk about some of the challenges of actually implementing this in practice and help deal with those.
Thank you so much, Annie. That was really, really helpful insight about the application of CMM to care and the real impact that it does have. Some of the barriers to replicating and scaling CMM in practice, I know I saw the chat and some of this is coming out in the chat. One of these is just access to clinical pharmacists to implement CMM in practice. And, we have many regions across the country, whether urban, suburban, rural, that it's not clear who those pharmacists are and where they are. And so, we're trying to do more as a profession to make sure that those sites that have a need and want to do this have access to clinical pharmacists to implement CMM in practice. There's also the lack of reimbursement and payment for pharmacist clinical services. And this was highlighted a bit in the National Academy's report that I mentioned earlier, that, and one of the main reasons too for why we need this team-based model of payment reform in this country. And Right now, this goes back to pharmacists, there not being a sustainable mechanism of reimbursement and payment. What happens now is that those sites where there is a sustainable model, they're often in states that have figured out how to do this within their own state areas in a sustainable way, or it is really for lack of a better word, a hodgepodge of different things that the pharmacist does to bill and code and get reimbursement as part of that team to sustain their services. And that could be some incident to fee-for-service billing. It could be some chronic care management codes. It could be Medicare wellness visits. It's a variety of strategies. Value-based contracts are emerging as really important, obviously. But right now, there's just a collection of strategies that pharmacists are using across a number of sites to do this. We do have examples, though, where practices have simply invested in the services of a clinical pharmacist simply because they see the return on investment and the data that we showed earlier. So there is some of that, a lot of that across the country as well, where that is already recognized and happening. Next slide, please. So what is needed to replicate and scale CMM? Clinician and interprofessional team awareness of CMM and its value to patients in their practice, and then obviously access to the pharmacist to make this happen. We do need payers and providers to support and invest in CMM. And this is a host of providers. It could be commercial payers, self-insured employer groups, ACOs, Medicare, Medicaid. And then I mentioned the pipeline of pharmacists trained to do this. And then tools and guidance for CMM practice implementation. I think someone in the chat asked about the how. How do you do this? One of the things that came out of our research with colleagues at the University of Minnesota resulted in this website, optimizingmeds.org, which we recently refined and updated. And you can go to this site and you can actually both click on CMM evidence and you'll see a lot of the articles that have already been discussed here on this call posted and links to them. And then you'll see additional articles I referred to earlier with respect to the how, with respect to the philosophy of practice management, and so on. And then there is, in this site, we have what's called an implementation system. And we have a lot of clinical pharmacists across the country who are actually using the implementation system to walk them through how to do CMM, how to deliver CMM in a practice, starting with how to make the case for the services. I think that there was another question in the chat as well. So we offer this tool and this guidance for CMM practice implementation, management, and monitoring, and to others. And we're constantly refining it based on feedback we get. But I would encourage you all to take a look at that, both for reference and access to much of the evidence we talked about today, but also really a how-to stepwise approach to implementing and improving CMM in clinical care. Next slide, please. At this point, I think we'll pause. I don't know, Amy, if we're turning it back over to you or turning it over to GTMRX.
I think it's me at this point. I thank you both for those very compelling and thought-filled presentations. We have a lot of chatter going on in the chat, which I think is very encouraging. And some of it is questions and some of it is conversations. So I think a good mix. At this point, we will transition to the Q&A portion, and I'll be doing my best to keep up with the chat and present some of the questions to both you, Mary, and Annie. And I'll start with one I'm going to direct it toward Annie. In the chat, we saw a question. I am a geriatric care manager, and this all makes sense. But how do we get PCPs on board to reach out to pharmacy specialists to review these patients?
Yeah, that's an excellent question. And I think some of it depends on kind of the way that the CMM practice is structured in your area or your particular practice. I think from a pharmacist perspective, being able to illustrate the value prop, not only in terms of what the patients can get from it, but also what the clinician can expect to receive, and really helping to educate clinicians on what this service is and what it's going to look like for their patients and for them as primary care clinicians is really key. For example, in my own practice, when we implemented comprehensive medication management within our practice and actually had a pharmacist join our group, we actually embedded her in our group of clinicians. So she was on our list, our Outlook distribution. She came to all of our clinician meetings. We really elevated her into a role of clinician partner with the colleagues in the clinic. So she was seen as very much, an extended and trusted member of the care team. And as such, had an opportunity to really develop relationships with the primary care clinicians who would be referring to her. And I think that was one of the keys to success, was really positioning her from the very beginning as a trusted member of the team and allowing those relationships to grow and build. Now, having said that, we were fortunate to have a structure and a model and a payment system that would allow for that. I think if you take a step back, the biggest thing, and one of the reasons that I think it's so great that GTMRX is doing this, is to really provide the education. There may be primary care clinicians, case managers, and others who don't even know that this exists or what it could look like in their practice. So I think, starting from a place of, let's get us all on board in terms of understanding what this is, because honestly, once you understand what it is, the service really sells itself for most primary care clinicians.
Oh, great. I couldn't agree more. That's been my experience too in my interdisciplinary practices in the past. Mary, I'm going to direct this next one to you. It really underscores some of the barriers that you shared related to wide-scale implementation. I suspect actually that both Mary and Annie have something here from different perspectives to share, but let's start with Mary. So the question as written is CMM is ideal. I think that's what was meant. The big question is who, how, and who pays. In a city, for example, where care is disjointed with multiple health systems that have no way of communicating and lack of resources for patients.
Yeah, thank you, Amy. I think Annie and I can probably both address this from a different perspective, but the who we talked about, the who is really, it's the team, but who delivers the care is the clinical pharmacist. And that may mean, though, in some cases, I think there was another question about how do we make providers aware that pharmacists are there to do these services, and that has to do with access to the pharmacist. And so I think the who is there, it's whether or not a practice has access to someone or is even aware that that is an option. I know we got a request in North Carolina with a group of practices in one of our regions that was very interested in how do I get access to someone. Serendipitously, we had just started a telepharmacy program, and so we were able to offset some of the pharmacist's time and sustain their time through chronic care management codes with these practices, and provide the providers access to this pharmacist to see their highest risk patients via telehealth. This was throughout the pandemic that we started this. So, so much of these efforts occur at the local and regional levels in order to get providers connected to pharmacists and so on. The next question was about the how. How do you do it? And, there's, I think, a couple different hows here. There's how do you deliver CMM? And there is access on one of the slides to an article on the patient care process. So what are the steps to collecting and assessing and coming up with a plan and documenting and implementing and following up and so on. So there's that how. We also have that how-to guide on how to integrate your services within the practice. Again, for the how, I would encourage or point everyone to the website. The CMM implementation system is a series of about 8 to 10 steps that walk you through how to do this, all the way from how to make the value proposition to the practice and to the leadership, all the way through how to care for the patients, and then how to evaluate the impact of your service and tell your story on the back end. So I hope that what we've compiled in the website will address some of the how. And then the other part of the question is who pays? And that's the $1 million question right now is, and I know that that's, you know, a big part of GTMRX advocacy and educating is to really work with payers and employer groups and others to make the value proposition, make the case for CMM services, looking at the impact on the quadruple aim, the return on investment, and trying to set up some of these relationships. And so I know that's not a magical fix to the who, the how, and then the who pays, but I think we do have a lot of resources out there. I know GTMRX has provided a significant amount of resources as well, available on their website that also begin to address much of the who and the how, and then the how do we pay. Annie, would you like to add more to that?
You know, I think you summarized it perfectly, Mary. The only thing that I would add is just that, you know, the conversation that, you know, systems are having internally around this, I think there are different levers that you can pull to sort of justify the use case for why you'd want this in your practice. Certainly the quality piece is important. Certainly, you know, lower total cost of care, you know, that's a compelling factor. But, you know, I think that also we are in this time right now where more attention is being paid than ever before. And I'll just say as an aside, you know, a big part of the work I do is around clinician experience, where that really is, you know, this notion of clinician burnout and how do we create joyful, sustainable practices, that has become part of the conversation in a way that it never was before. And I think getting clinician engagement to really be, you know, just advocates within their own care systems and saying to leaders, you know, this is a service that we really want for ourselves and for our patients and for the service that we can provide. I think that bringing the clinician voice into that conversation, once they understand what it is also really important. And then just from an operationalization piece, you know, we use Epic as our electronic medical record. There are certainly others, but I think the more that you can do as a care system or a practice to make it super easy to get that patient connected to that pharmacist service is really important. For example, we actually have an order that we use in our EMR that if I place the order, it drops to a scheduling queue. So somebody's actually not going to let that patient slip through the cracks. They're actually going to pick up the phone and call the patient, or they're going to stop at the front desk. So we've tried to embed those pieces to make sure that, you know, if I'm going to spend the time as a clinician teeing up and explaining to my patient why I think this is a good thing for them, that we're not then going to drop the ball operationally and not actually get them connected and sitting in front of the pharmacist either in person or virtually. And the other just piece of that is that, you know, this whole explosion of telemedicine has been huge for us in terms of being able to bring this service to more patients that had transportation barriers, you know, time off work barriers, those kinds of things. So I think the time is really ripe to be pushing this message and trying to expand the reach and breadth of what we can do with comprehensive medication management, using this as one of those, you know, fortunate silver linings of COVID as an opportunity to really expand that.
Thank you. Excellent. Annie, I'm going to stick with you for a second with a somewhat lengthy lead in here. This next question is really around the logistics and the roles and responsibilities of the various team members in an interprofessional team. And so the question is really about, are there good references that describe the role and responsibility and the boundaries between pharmacists, primary care physicians, specialist physician, nurse care managers, specialists, CIN, ACO, health plan, et cetera. Probably many ways to divide and conquer, but which ones work. So I'm going to ask Annie to share how these different relationships are interconnected and delineated within her practice. But I also want to direct everyone to the GTMRX webpage, where there are a number of resources and toolkits, some of which at least partially address this question, and some of the others in the chat that we're not going to have a chance to get to. So in particular, there are use cases within different types of health settings like ACOs or integrated health systems and others that you might find useful as you're wrangling with these questions. So Annie, if you wouldn't mind describing the roles and responsibilities in your practice.
Sure. So I'm gonna give you the sort of the very narrow scope answer, and then I'd love to have Mary weigh in on sort of some of the broader things because she's done a ton of work in this area, and I think probably can speak much more intelligently to to the bigger question here. But the way that we have operationalized this in our practice is we have what's called a collaborative practice agreement with our clinical pharmacists. So a collaborative practice agreement is essentially a document that outlines the scope of practice for the clinical pharmacist. And this is something that, I, as a clinician, clinic medical director, review and sign off yearly, and we make updates to those as new therapies become available, as, practice guidelines change. But basically the idea here is that, as a care system, we have established sort of what that pharmacist's role is, what sorts of conditions they have a collaborative practice agreement to manage, what that management looks like. And it's a way of really standardizing the care that's being delivered by that person on the team. And actually, this has been a huge part of getting buy-in and acceptance from our clinicians. So the clinicians can feel confident that we don't have a pharmacist who's just going to go rogue and do whatever they feel like, but that they're actually going to be practicing within the, the guidelines that we as a care group have established for how we want this care to be delivered. So, I highlighted a couple of examples in the case study, but, our clinical pharmacists have collaborative practice agreements for, among other things, diabetes management, hypertension management, lipid management, asthma management. So we can, and we educate our clinicians on sort of what that scope of practice looks like, so that it helps our clinicians with the selection process of saying, this is a patient that I would really like to send to a clinical pharmacist because I think that they could benefit from that service. So we do that using a construct of collaborative practice agreements in terms of actual care delivery. Mary, what more would you add in terms of like the broader relationships and how those things are defined?
No, I think that not a lot, Annie. I think that's great. I think every practice and every situation is different. I know we have many pharmacists on the call here which have their own story to share about how they operationalize everything, how they develop those relationships. I've been in 3 different outpatient practices throughout my career and built those relationships and developed it differently based on the individuals and the teams and the size of the teams I was working with. In one particular practice, this was so new to them, and there were 8 different providers, 2 who were really opposed to having a pharmacist in the practice. And I literally spent 6 months just observing those 2 providers and building a relationship and building a rapport until it got to the point where they came to become dependent on me. The other ones were a little bit easier to sort of, build the collaborative practice agreements with and to get, kind of hit the ground running. But in each situation, the relationships are critical to how you operationalize any of this. And I think it has to be tailored to those that you're working with.
Great, thank you. Mary, I think I'm going to direct this last question to you. We have only about 2 minutes left here. So there's curiosity around how the model of CMM differs from existing patient management programs already in place with specialty pharmacies and pharmacists. I'm thinking about MTM and other sort of existing models. So how is CMM different?
Yeah, it's a really good question. And unfortunately, I think we are fraught with a lot of terminology. I think we all recognize that. And so comprehensive medication, well, let me start with medication therapy management. It's come to mean so many different things to different people. And it really sort of got its name, if you will, around the inception of Medicare Part D. It became known to be something very different than anything comprehensive. And so we have a lot of terms that we use. Actually, we also just published a paper recently on the CMM alphabet soup, if you will, in the Journal of the American College of Clinical Pharmacy that we can also point to. And CMM is really that whole person comprehensive approach. And it is a model that now has an evidence-based patient care process behind it for how you do it. I don't think that can be said for a lot of other interventions or services. And so I think what happens is that depending on which pharmacist is doing what and in what setting and in what organization, regardless of what you call it, pharmacists are often doing different things and going about their intervention in the delivery of the service in different ways. With CMM, we really just try to standardize and ensure a consistent approach, because then that's what leads to the positive impact and the benefit. So, you know, it could be that some people in specialty pharmacy practice are providing CMM. It very well could be that that's what they're doing. And in other settings, it may not be. So I know we just always encourage pharmacists when they're talking about the intervention and the care they're delivering to make sure they're explicit about what it is they're doing. And in this case, we're talking obviously about the comprehensive approach to medication optimization.
Thank you, Mary. Thank you, Annie. With that, I think that will mark the end of today's event. On behalf of the Get the Medications Right Institute, I want to thank our speakers and the audience for joining us today. Please fill out the survey you will receive after the session and stay up to date about GTMRX activities. Hope you'll follow us on Facebook, LinkedIn, and Twitter by searching GTMRX Institute. Thank you again for joining us and have a wonderful day.